Do you find consultations with people living with chronic pain challenging? Is this leading to a loss of rapport between you and your patients and lowering your confidence in helping people with pain? In part one of this video, I'm going to talk about 2 common challenges faced during consultations with people with chronic pain and how to address these. This will enable you to have more productive and effective conversations, save valuable clinic time, and reduce the heart sink moments that you may be experiencing when seeing a patient with chronic pain. If you don't already, I'm hoping this series of videos will help you find chronic pain consultations rewarding, improving your job satisfaction. Hey friends, welcome back to the channel. If you're new here, my name is Mahin and I'm a physiotherapist specialising in pain management based in the UK. On this channel, we explore ways to improve our conversations with those living with pain so that we can help them create healthier and happier lives. Today I'll be going through part 1 of the top 5 challenges faced when working with people in chronic pain. So let's get into it. To begin, I'm going to take you through a consultation that happened 4 years ago and one that you may be familiar with. Sandy sat across from me in the clinic room, the frustration clear on her face. I had just tried to explain why her tests had come back normal and the brain's involvement in pain, and clearly, by her response, I had done a pretty bad job of it.
Are you also trying to tell me that the pain is all in my head?
My heart pounded in my chest. How the hell am I going to get out of this one?
I don't believe that my MRI has come back normal. It must have missed something. Isn't there another type of scan you can do?
I told her there wasn't, and I mumbled quietly about all the different factors involved in pain, including psychological factors.
Psychological? Do you think I'm making this up? I'm in pain.
Shit. I tried to reassure Sandy that I believed her pain was real and I wanted to help her manage it because I thought that getting rid of the pain completely wasn't a realistic aim.
That's just not good enough. I don't want to have to just put up with this pain for the rest of my life.
Sandy stood up and stormed out of the room. I stared at the chair that she'd been sat on just seconds before, wondering how that had gone so badly wrong. I never saw Sandy again. I hope that she found someone who could provide a better explanation for her pain than my poor attempt, and I hope that she's been able to make more sense of what's going on. You may have seen many patients like Sandy before, and you may have even had very similar experiences to what I had in that consultation. I promise you, you are not alone. These challenges are very common, and I'm asked about these in most conversations that I have with other professionals working with those people living with pain. I'm hoping this video helps to reduce experiences like that and gives you more confidence in talking to people with chronic pain. Consultation with Sandy from 4 years ago was from before I started working in pain management. The challenges faced in that consultation are now ones that I see daily. Thankfully, I'm much better equipped now at navigating those conversations, reassuring and validating patients' experiences, and helping them towards a life of living well with pain. Before I go into the next part of the video, I want to make it absolutely clear that the one thing that has helped me the most with these common challenges is now being able to speak to people as people rather than patients. Stepping back from that paternalistic, 2 sides of the table approach and meeting patients with pain where they are with honesty and transparency. Rapport and trust building is absolutely key. Let's now go into 2 of the top 5 challenges faced when working with people in chronic pain to make those conversations less daunting, more effective, and more productive. This is a really common challenge that we face when we're speaking to people with chronic pain, and this is largely because people have probably tried to explain the brain's involvement in pain before and either done a pretty bad job of it or it's been misinterpreted in some way. But it's a very, very common challenge that we face, and it's a very difficult thing to explain as well, chronic pain, because of the lack of correlation with test findings and so on. So it's really important that when this pops up in conversation or you feel like you might be teetering on the edge of this, is to actually reassure the patient that it's very common for you to hear this from other people that you're seeing with pain, that they've seen a professional before and it's been suggested that things are all in their head. So this is not uncommon to hear this. And then let them know that you hope to provide some more insight into this today so that you can clear things up. What I like to do is I like to make it really clear at the beginning that at no point throughout the conversation am I suggesting that the pain is all in their head or that it's made up. And I like to say this first of all because I also like to give the patient then permission to interrupt me or to challenge me if they feel that I'm implying that the pain is all in their head at any point. It's really important that we don't skirt around the brain's involvement in pain because our brain is our control center for everything, including pain. So just as our brain is responsible for our sight, smell, touch, and taste, just as real as those senses are, so is pain. But it is that our brain is the control center for everything, so it determines how we see something, how we smell something, but also how we feel something and how we feel pain. Also take some time, maybe a couple of minutes or so, to quickly explain explain how pain works. You don't have to go into massive detail here, but it's just important for the patient to know what the brain's involvement is in pain, so that if it is suggested, or they feel it's suggested at any point in the future, that someone's saying that it's all in their head, they may know what that clinician is they're actually trying to say. So I usually explain it like this. So along our skin and our muscles, we have sensors, and those sensors pick up changes in mechanical pressure, chemical changes, and heat changes as well. Now, what happens is, if one of those sensors is set off, so let's say that you put your hand above a flame, your hand above that flame will mean that the sensors within your skin will detect that there's been a change in heat. And what it will do is it will send a signal, okay, across the first nerve to the spinal cord, saying there's been a change in heat. At the spinal cord then, that signal will jump across a synapse, which is a little gap between nerves, and it will travel up to the brain. Again, all it's saying is that there's been a change in temperature in the hand. At this point, that signal is not pain. It is just a signal telling the brain that something has changed at the hand, okay? Now, when that signal gets to the brain will then decide whether this thing needs to be protected against or not. Okay, so it will determine whether it's a threat, and if it is a threat, then it will respond with pain. And the brain will draw on things like our past experiences, our thoughts and our beliefs, our expectations, our fears, our concerns, and also the perceived threat that there is. So taking all of that into account, if the brain then decides that this needs to be protected against, it will then send a signal back down that second nerve, across the synapse, and across the first nerve, which is then saying, okay, well, this is painful, and that pain will then cause us to take the hand away from the flame. Our pain's our protective system, as we're going to go into a little bit more detail in a moment, but that is how pain works. So initially, it's just a signal saying there's been a change. Our brain then decides whether it needs to be protected against, and it will send the painful signal back down. Minutes to explain that to patients, but it's worth doing because I think it's a really helpful way of understanding how pain works. And make it really, really clear here that this is how all pain works. So not just chronic pain, but all pain. So our brain is our control center for all pain, not just chronic pain that isn't explained by scans or investigations. Check the patient's understanding and ask them if they've got any questions about that. It can be really, really confusing for both us and patients when they're experiencing a lot of pain, but tests, scans, investigations are coming back and not showing an explanation for that pain. This can be very distressing for patients, and it can make them feel like their pain isn't taken seriously, or they can even start to doubt themselves about the level of pain that they're experiencing. Regardless of whether they say that it's been explained to them or not, ask for their permission to explain it again to them. I'll now go through how I explain pain to patients. So we know that pain is complex. We used to think that pain only existed because of damage, and that damage would be seen on scans and we'd know what the cause of the pain was. But over the last few years, we've started to understand a lot more about pain, and that there are a wide variety of factors involved with pain. And this is even more so in pain that lasts longer than the normal tissue healing time of 3 months. And this is why it's actually very, very common for tests to come back normal, not showing an explanation for your pain, but you experiencing a lot of it. And the reason that is because pain is one of our protective systems, and it responds to anything the body sees as threatening. Now, we have a few different protective systems. So our pain system is one of them, our fatigue system is another, our stress system is another, and our immune system is another one. But pain is one of those protective systems and responds to anything the body sees as threatening. Now, this can be, if you twist your ankle, pain's there to stop you from walking on it, to protect that ankle. But pain also responds to other things the body sees as threatening, such as stress, poor sleep, lifestyle changes, changes in activity levels, previous trauma, illness. And the confusing thing is that pain doesn't tell us what it's responding to, it just shows up as pain. Now, when pain persists, so when it goes on for longer than 3 months, it means that our pain system, that protective system, has become overprotective. So it's almost become a little bit too efficient and too good at what it's trying to do. It's now protecting against things that aren't particularly threatening, but it's still showing up as pain. And this is why things that previously weren't painful become more painful to do. This is a really kind of quick, easy way to explain pain to people. And I like phrasing it with pain as our protective system, because I think it kind of links in with other protective systems, and patients may see a bit of a similarity there. So they might feel that, okay, when I am feeling particularly stressed, for example, my pain does get worse, and so does my fatigue, and actually my immune system's not as good as well when I'm stressed. And it can start to, allow patients to make certain links between what might be causing flare-ups of their pain. The other thing is it draws on other things that might be causing pain that have happened previous in life before. So I mentioned trauma to patients, not to kind of elicit anything out of them or get them to kind of say anything to me that's happened in the past, but just to get them thinking about maybe other causes of their pain as well, because we know that there is a big link between chronic widespread pain conditions like fibromyalgia and past trauma as well. So it's important to just explain it in that way, and it's a fairly quick way of explaining pain. I actually don't mention the word biopsychosocial to patients because I just don't know how much that actually means to people. It's just a collection of words really, and it's a phrase that I'm growing less fond of. Instead, I like to explain that during certain stressful periods in life, our body can't display what we're feeling through emotions, so it displays it via physical sensations instead, such as pain. And I actually took this explanation from the book, Is It All in Your Head, that I'll leave a link to in the description below. And this is a really insightful book by a neurologist who sees a lot of patients with medically unexplained symptoms and even things like kind of paralysis and non-epileptic seizures and things like that. And actually how that's been because of trauma, previous trauma or stressful periods, and the body is then displaying what they're feeling actually through physical sensations and physical symptoms rather than emotions themselves. We can't always display emotions as humans, and actually our body has to have an outlet in some way, and sometimes that's through pain. And in short, I explain to patients that anything that makes you unhappy makes your pain system unhappy and more protective. And then we go through any examples from their own life where they feel that this relates. And at this point, patients start to pick up on certain things like, actually, yeah, you know what, this pain did start after a particularly stressful period, or my flare-up, when they do happen, they are actually after a period of bad sleep or whatever it might be. And again, we're starting to make links here. It's important to go through patients' own experiences with this because anecdotal evidence often holds a lot more weight than, let's say, research evidence or theoretical evidence that we're speaking to patients about. And we can use other examples of pain such as headaches or even other physical sensations such as sweating, increased heart rate, shallow breathing when we're nervous to illustrate our point here. Okay friends, so next week I'll be talking about the next 3 common challenges faced when working with people with chronic pain. We are going to be discussing the mismatch in expectations of treatment, with patients understandably wanting relief while we may only be able to offer management. We'll also be discussing the vital shift from what is the matter with me to what matters to me, which is key. Okay, and the last thing we'll be discussing is the challenges of increasing pain with physical activity and patients who've been through exercises and stuff before which has flared up their pain, and how this offers challenges around kind of exploring that as a treatment option in the future. To cap that off then, I'll also be explaining how we can help patients increase their activity levels in the presence of pain. If you found today's video helpful in finding different ways to explain pain to patients, then check out my Persistent Pain Explained video. This goes into more ways that we can explain pain without it becoming too complex and confusing. Thanks for watching, take care, and I'll see you for part 2 next week.